Welcome to Mad Medicine with Miss P. My phone just shut off after 4 minutes of filming, so if it does it again, there will be no video this week because I don't have time for this crap, and I'm going to chuck this piece of dog crap phone that I just purchased not too long ago across the room and smash it into a million pieces. And then I'll have the satisfaction I deserve. So today we're going to talk about antibiotics. Now, as I was saying before my phone shut off, I know antibiotics are pretty simple. Everyone's been trying them. Everyone's used them. Everyone's had them. Everyone's administered them, whether to your family member, a child, or to a patient as a nurse or student nurse. And they're pretty simple. It's not too confusing. Antibiotics are, and that's why I don't like the term anti-infective, because they're not going after the infection. Your body's infected. They're going after the organism that is infecting the person. So it's an antibiotic because it's anti-bio, meaning organism, life that is not, invited to be there. So you have to think about how they work. And while it's not vital that you understand how they work, it is kind of interesting just to know that antibiotics in general work a little bit differently. Some specifically penetrate the cell wall of the organism, get into the nucleus, break that up, all those guts kind of fill out into the cell itself, out of the protection of the nuclei, and kill the cell. Some of them break down the cell wall, so then all the guts fall out and your body can kill it easily. Some stop replication. At any rate, however they work, it's important to understand that they're going after the organism that is infecting the person, not the person. So when a patient tells me I'm allergic to penicillin because it doesn't work on me, that just blows my mind. And you won't believe how many times people say that. I've heard it more often than I want to. It is absolutely asinine. And depending on how stupid the patient is, I'll attempt to explain it to them in the sense that antibiotic isn't going after you. If it worked on you, you would be dead because it's going to kill the organism that it is targeted to. And by targeting them, we get a culture and sensitivity. So when we get that CNS and whatever it may be, urine, sputum, blood, whatever kind of culture and sensitivity we get that report back, and it tells us the name of the organism, what it's sensitive to, what it's resistant to. So those three things are vital to know. So the doctor has to order a antibiotic that this organism is sensitive to, so it will kill it. If you get an antibiotic that this organism can give the finger to and is like, what, I hope you brought friends because you're not going to do the job, then it doesn't work on the organism because it's the wrong antibiotic for the organism that it's supposed to kill. So it's important to recognize the whole point is we are going to kill the organism. So with your nursing interventions, that's one thing that has always gotten me. And I'm sure, there's instructors out there that are okay with you guys writing all these ridiculous nursing considerations down, and which to me make no sense. It's always like, watch for urticaria or, rash. When are you not going to do that? When are you not? That's like saying, watch for choking when you give this pill. When are you not going to see if your patient's allergic to the medication you're administering? When is that not a thing? So don't write that crap down. It doesn't mean anything. What you actually want to do is look to see, is the patient getting better? Instead of monitoring for nausea, vomiting, diarrhea, upset stomach, hallucinations. A patient yesterday told me that he's allergic to Levaquin because it made him depressed. I can't. I just kept on going. I pretended like he didn't say that. I don't care what rare or very common side effect you get. Nobody cares about that. That's the benefits outweigh the risk, or they don't. But that has nothing to do with a nursing consideration. I don't care about that, and that's not an allergy anyway. What I want to know is it killing the organism? Is the patient getting better? What types of things are we going to look for to see if the patient is no longer infected? So you're going to look at the site. If they have a cellulitis issue or a dog bite or whatever area that's infected that you're treating, look at that site and is it getting better? Otherwise, you're going to be checking the white count when the doctor orders it. You're going to be looking for fever, flushing, chills, all the things, the temperature, their temperature, their fever. All those things that tell you, is the patient infected? And a lot of times with a local infection, like cellulitis, that sort of thing, we'll even draw around it, with a marker and make sure that it's not spreading so you can tell if it's getting better. All those other side effects and that sort of thing, You might want to change the antibiotic if the patient's that miserable on it, if they're having significant side effects, mention it to the doctor and they can order something else. But none of those have anything to do with why the patient's on it and is it working. So if it's upsetting your stomach or it makes you nauseated, that sort of thing, but it's the best medication to use for that organism, well, the benefits may outweigh the risk, and you're just going to have to take it. And we'll give you some, make sure you have something in your stomach before you have it, or we'll administer it with Zofran or whatever it is, or plenty of fluids. But those are rare and not detrimental side effects or adverse reactions of the medication. Those are not allergies. We're always going to look for allergies. Anything that turns you red, makes you itch, or swell. Those are histamine responses, and those matter. Everything else, well, I don't care. It's not that important. And I'm assuming these patients just want to seem more important or have things to complain about or add things to their list. And you'll find plenty of those patients like that. And one day when I start reading off all of these ridiculous things I've gotten over the years from patients, doctors, nurses, nursing students, you'll kind of feel it with me, and you'll see it all is pretty comical. Always make sure that you complete that antibiotic. Of course, we all know that, whether it's you taking it at home or whether it's your patient, you have to make sure that those patients are getting that complete medication. So you have to try to be on time with those doses as much as you can. You can't go for a long period of time and allow those organisms to multiply and get stronger and survive and then try to kill it with the next dose. That's not how it works. You have to stay consistent. And a lot of these medications have peaks and troughs, like Vanc is one of them. I'm sure there's others, but for the most part, Vanc is the one that we notice most often with a peak and a trough. So you're going to take it at its lowest point and then check that blood level again at its highest point and make sure it's high enough in that bloodstream to do the job. And those are usually people that are very sick. This isn't like an oral medication you're taking at home and having your blood drawn. These are patients that are in the hospital with IV antibiotics because they're that sick. And then do things to decrease the risk of further infection, obviously. Not just hand washing. That's a given. Everyone's going to wash your hands until your skin peels. We're all going to do that. But it's other things, the amount of visitors. Now, this is like, pre-pandemic and that sort of thing, but you still have to monitor visitors and who's coming in. And it used to always drive me insane when I was in the hospital and, with the students. And, there's a big thing on the big fluorescent yellow sign on the door that says, all who enter must wear a mask. All who enter must wear gown and gloves or whatever it is. And the family members would just walk in, like it's no big deal. And especially if it was a droplet thing, I'm like, you are introducing, you're increasing your risk of introducing more infection to this patient who's already compromised. So you should either not be visiting at all because you don't know what you have. And a lot of, people don't know what they have. And especially the contact really drove me insane because they bring in these little kids and they're climbing over all over the floor, on the floor, in the hospital room. These patients' children or these family members' children are on the floor all over. Then they, want to crawl up in bed or kiss, grandma goodbye or whatever. And it's a contact room. That means everything in that room is contact. That means that organism, whatever it may be, could be on anything that's inside that room. Nothing should go in that is coming back out that's either not disposable or cleanable with something that is, strong enough, powerful enough to clean, some purple wipe or whatever saline cloth that can kill that organism that has been proven to be able to kill quite a few of these organisms, especially one that's so communicable. So whatever it may be, and yet these family members would walk in and out and they would, say like, I would say, you need to wear a gown and gloves, to be in this room. They're like, oh, well, no one said anything last time. And I'm like, well, good for you and them. Obviously, they don't care about you contaminating this patient further or taking whatever you've got home to whoever you have at home. Or if they're coming in and they're getting close enough to where droplets can get onto this patient who, has some sort of pulmonary infection, and they just don't recognize at all that they could be contaminating this already immunocompromised person, I would have to say something, keep your distance, don't visit, or, wear a mask. And especially if anybody was in there, coughing and hacking and gagging and was obviously sick, you would have to say something that you could, further infect this patient who's already, clearly sick. And if they didn't or refused, I would tattletale. I would write a note in the chart. I would tell my supervisor, and then I would write a note in the chart that says, in the either the safety portion or just a nurse's note that would say, after repeated encouragement for patient's family to wear PPE, they still, continue to refuse, and, make a note of anything they said, quoted, or that sort of thing, because these patients are sick and they have an infection. Now, do I think a non-infected person can infect another non-infected person? No. Do I think that, an airborne aerosol virus or bacteria is going to be, stopped by, a piece of paper over our faces? Maybe not, but those people probably shouldn't be um, being visited by other people, or even the staff members. We're going to do everything we can to greatly reduce our risk of cross contamination. But somebody that's on an antibiotic, you have to see if it's working. Don't skip doses, monitor for the infection, complete that prescription, and then recheck when it's all over. Make sure that it did the job and that their bacterial load is significantly decreased, or that they need something additional. And I've been into rooms where they've been on 2 or 3 different antibiotics, and we're hanging them one after the other. And this patient is, obviously very sick. So, um, now with your nausea, vomiting, and diarrhea, you're going to get that with almost any antibiotic. Think about what it's doing. It's going to kill all the bacteria in your GI tract. A lot of these patients are on a probiotic also. A lot of these patients that are on a probiotic, as well as angiotensin, or sorry, uh, H2 antagonist, these people are a great risk of having GI issues. You're killing all the natural bacteria and taking away the acids that kill the things that are supposed to help that bacteria survive. So you're going to have C. diff and those things. So monitor for them and report them when you get them. Do something about it. So that is it with antibiotics. Pretty simple today. And maybe we'll do H2, and I just remembered I haven't talked about those. Maybe we'll do H2 antagonists next week or so. I don't think I've done those, and that'll be a quick little video too. But because you see them so often, you really need to know your H1s and H2s and how they differ. So maybe we'll do that next week. Anyway, that's it. So my pet peeve for the day, yesterday I thought I was going to get shot at because I was screaming at the person in front of me. Please, for the love of God, stop trying to get on the highway doing 40. Those people that you're merging with are doing 70, 75, and 80. If you try to get on the highway doing 40, you're going to get killed or get somebody else killed. For the love of God, pump the gas heading on that ramp. Oh my God, this jerk off was literally doing 40, and I'm screaming at him to go. I almost laid on my horn. And then I guess because this lane was like being worked on, so it was like kind of that rough, patchy, graded, like that, he thought, oh, well, I'll just go ahead and get over instead of using that lane to increase speed before getting over. And then he put his window down and stuck his hand down and was like motioning to me, and I don't know what he was saying, but had I thought about it, I would have let him go ahead and get killed and then stayed in that lane, punched it, and then merged over. But it was too late, and there was enough open traffic to where I just kind of got around him. And then later he comes speeding by me. Oh, so you do know where the gas is? I can't. Oh my God. That's why I keep my gun in the lockbox, which would require a combination and concentration to get it, because otherwise I'm going to end up in jail. God bless them. Okay. So as always, face your fears, forget your failures, follow your faith, and I'll see you next time. Hey, 13 minutes, not too bad.